Today we're discussing a case of a 79-year-old gentleman who presents to his dermatologist with a large ulcerated lesion near the clavicle. He reports that the lesion was there approximately 5 months while he was living in Florida for the winter. The lesion was biopsied. It was found to be a cutaneous squamous cell carcinoma, and standard excision was performed with 4 mm margins with postoperative margin determination to be negative. The patient did well for several years until representing in May of 2018 when he shows up to his dermatologist, now with lesions that are surrounding the area where the original lesion was, including signs that there was dermal spread and regional lymph node involvement. Imaging at the time that the patient presented to his dermatologist with the recurrence found that there was subcutaneous fat involvement and parotid node involvement. Biopsy confirmed that these areas were involved with a poorly differentiated cutaneous squamous cell cancer. It was staged as a stage 4, felt to be the original lesion was a T3, and now we had N2 involvement. The patient was felt to be best suitable for systemic therapy, and he was started on cemiplimab. My initial impression of this case is that, as we know, cutaneous squamous cell cancers are the second most common cancer presenting in the United States. And it happens in the elderly patients, more often typically white males. So not knowing the race of this gentleman, it fits in that he's 79 years old, presented with a lesion, and was taken care of primarily. Now, he recurred 2 years later. Why did he recur 2 years later? He likely had some risk factors that aren't well defined in the case. For example, we don't know the original size of the lesion. We do know that it was on the clavicle area, that it was resected to negative margins, but we don't know if it was into the subcutaneous fat at that time or if there was perineural invasion. So I'd want to know that, and I'm suspicious of that given that 2 years later he presents in this pattern where he has dermal involvement and lymph node involvement of the tumor. I'd also want to know what the health state of this gentleman is. Does he have diabetes? Maybe he has other comorbidities such as CLL. And then to the extreme, is he a transplant patient? I'm sure that would have been mentioned in the case, but not here. The general workup for a patient presenting with regional involvement, in this case, this gentleman had gross palpable lymph nodes. I'd be concerned the extent of the involvement, even systemic involvement. A workup should include, besides usual history and physical, looking for signs and symptoms, I'd also consider routine scans, in this case CTs of the chest, abdomen, pelvis. If there's any concern, even sometimes I'll consider imaging of the brain. General health should be assessed. That would be considering liver, kidney status. Are there underlying comorbidities such as HIV or hepatitis that I should be worried about too, as I'm starting to think about the systemic plan for this gentleman? I think the workup has changed a little bit over the years. I mentioned HIV and hepatitis C. So these risk groups also factor into some of the systemic therapies that we're considering, such as PD-1 blockade or other cytotoxic chemotherapies. But the general evaluation of looking at signs and symptoms and the scans that I mentioned have been pretty standard for some time. So high-risk features, we divide cutaneous squamous cell into low and high-risk groups. And high-risk features would include location, such as in the center of the face or on the hands or genitals. Those are high-risk areas. Size of the tumor, how extensive it is in terms of its depth of invasion or through the anatomic structures that it goes. We also consider factors such as the patient. Is this a high-risk patient, such as do they have derangements of their immune system, or is there an underlying DNA repair deficiency? So all these will factor into what the risk of recurrence is. We rely a lot on the pathologist or dermatopathologist to give us these variables back, such as has there been perineural invasion, what the size of these nerves might be that are involved, as well as the differentiation state of the tumor. Is it a poorly differentiated or a well-differentiated tumor? So these factor into the clinical assessment of the patient. Unfortunately, today we really don't have good molecular prognostic factors, such as in breast cancer, where we might be able to risk stratify patients, so we rely on these clinical factors.